morning, everybody. I think we're going to get started in the interest of time. We've got a few things to go through today. To start off, we have Andy Schaefer from the Department of Rheumatology for an update and kind of a proposal on anti-rheumatologic medications around the time of surgery. I'll let Andy introduce himself and get started.
Great. Thanks so much for giving me the time to give this presentation this morning. I'm one of the first-year fellows, rheumatology fellows here at the U. And this morning I'm going to be talking about perioperative management of medications that we commonly use for rheumatologic conditions. So the perioperative management of rheumatologic medications has historically been without any formal recommendations or much high-quality data to support decisions one way or the other. But many of our rheumatology patients are on immunomodulatory drugs at the time of TKAs and THAs, as you can see from the listed percentages on the slide here. And we do know that rheumatologic medications tend to increase the risk of infection. So deciding whether to continue or hold our medications perioperatively can be an especially important decision. So thankfully in 2017, in a joint effort by the American College of Rheumatology and the American Association of Hip and Knee Surgeons, guidelines for perioperative management of anti-rheumatic medications were published. And these are the guidelines that we're going to be touching on throughout this talk. And while having these guidelines is great, they're really only useful if people are informed about them and consult them when making decisions in real life situations. So in order to gauge knowledge and usage rates, there's an ongoing QI project here at the university in conjunction with the rheumatology, orthopedic surgery, and anesthesia departments. One of the interventions in this project is this presentation, which I'm giving separately to each department. And then I'm also providing a one-page quick reference handout as part of the intervention. And we'll be sending out a follow-up survey within the next month to compare with the pre-intervention survey that got sent out late last year to determine the outcomes of the intervention. And then separately, we're going to be looking a little bit at data from chart review of surgical patients on anti-rheumatic medications from both before and after the guidelines were published. It brings us to the guidelines themselves. And as when using all guidelines in a clinical setting, it's important to figure out whether they were developed with your patient in mind or if it would be appropriate to extrapolate them to fit your particular clinical scenario. And so these particular guidelines were developed specifically in situations in which adult patients who had rheumatoid arthritis, a spondyloarthropathy, juvenile idiopathic arthritis, or systemic lupus are undergoing an elective total hip or knee arthroplasty. And the recommendations within the guidelines were made by a panel composed of orthopedic surgeons, rheumatologists, an ID expert, a lupus expert, as well as patient representatives, with an additional input provided by an 11-person patient panel of RA and GIA patients who had a hip or knee replacement previously. Most of the evidence for the recommendations was based on indirect and non-surgical studies of low to moderate quality. Each recommendation did require at least 80% agreement, but all but one of the recommendations received unanimous approval. And the questions addressed by the guidelines are which medications should be withheld, for how long they should be withheld, when they should be restarted, and is there a dose of glucocorticoids that should be given to patients at the time of surgery if they're on chronic steroids. They determined that the most critical outcomes were surgical site infections within the first year after surgery, non-surgical site infections within 90 days of surgery, as well as rate of disease flares. Other outcomes such as hospital readmission, death, and long-term arthroplasty outcome were also deemed relevant. The panel ultimately attached far greater importance to infection at the time of surgery than to disease flares. Because RCT data was somewhat lacking, the panel assessed indirect evidence based on background risk with candidate drugs in non-surgical settings, and then separately the background risk of adverse events with THAs or TKAs when patients were not on candidate medications. Moving on to the individual medications and recommendations, the first one that they mention are the conventional DMARDs. These include medications like methotrexate, leflunomide, sulfasalazine, doxycycline, and hydroxychloroquine. These are felt to have possibly the lowest risk of any of the rheumatologic medications that we use. Because of this, there's actually a recommendation to continue these throughout the perioperative period if the patients meet the criteria of the guidelines. In contrast to the conventional synthetic DMARDs, biologic cessation is recommended prior to surgery. There's a list of a lot of different biologics here on the slide. There's more coming out all the time. It's recommended that surgery is scheduled at the end of the dosing cycle for the biologic, and then they may be resumed 14 days post-operatively if the patient has been evaluated by a surgical provider and has been confirmed to be free of wound healing complications, surgical site complications, or systemic infections, and once all sutures or staples have been removed. So just to go over a few examples of when to schedule surgery in relation to these dosing cycles, the panel did recommend that surgery be scheduled for the week or month following the week or month when the next dose of the biologic would be due. For example, if rituximab is being dosed every 6 months, surgery would be scheduled the first week in month 7 after the rituximab was held. It's obviously not always practical to schedule surgeries at those exact times, but they recommended attempting to arrange for surgery as close to those times as possible. Next up, we do have a couple of small molecule targeters, which include medications like tofacitinib, baricitinib, and upadacitinib. And these medications are usually stopped for 7 days prior to surgery and then resumed in a similar manner as with biologic agents. When they considered medication use specifically in systemic lupus, biologics such as Benlysta followed the same guidelines as the previous recommendations for biologics. These specific recommendations that are touched on here are for the non-biologics commonly used in the setting of lupus, which include mycophenolate, azathioprine, cyclosporine, and tacrolimus. And they separated patients into 2 groups for this, severe and non-severe lupus. The criteria for severe lupus are in the box to the right of the screen. They require current treatment for one of those conditions in order to be considered severe lupus. If those are not present, they're categorized as non-severe lupus. So in severe lupus, it's recommended to continue these medications perioperatively, whereas in non-severe lupus, you can consider discontinuing these agents 7 days prior to surgery and then resuming them 3 to 5 days after surgery in the absence of complications similar to those listed for the biologic medications. The final category to mention is steroids. The panel recommended against administering stress dose steroids perioperatively. However, it is worth mentioning that this recommendation does not refer to, for example, JIA patients on steroids who received steroids during childhood developmental stages, or to patients on steroids to treat primary adrenal insufficiency or primary hypothalamic disease. And then if possible, they also recommend tapering prednisone to less than 20 milligrams per day before surgery. A few limitations noted by the guideline authors are listed here. It's not entirely clear how these can be applied to patients receiving non-TK or non-THAs or to non-elective surgeries. They did not find high quality evidence for any of the recommendations, and some of the evidence that was found in the setting of methotrexate and leflunomide use, for example, was at doses that are lower than those commonly used currently. For these reasons, all the recommendations published were given a conditional rating. And here's a quick snapshot of the handout I made as a quick reference for the guidelines, and I'm going to include that in the follow-up survey email we'll be sending out in about a month. And I think that's all I have this morning. Thank you again for letting me give this talk.
Thank you, Andrew. Does anybody have any comments on this at this point in time? I appreciate the update. I think for many of us, it's helpful to kind of revisit this from time to time. Okay, great. We'll look for your follow-up survey.